This information is for educational purposes only. It is not intended to substitute for professional medical advice and should not be interpreted to contain treatment recommendations. This module will cover the components of an ostomy pouching system. During the postoperative period, you may need to select an ostomy pouching system for your patient. It is important to explain the rationale for the pouch selected because their pouching needs may change as the abdomen and stoma change over time. There are two components to a pouching system: the adhesive portion, known as the barrier, and the collection device, known as the pouch. Other names for the barrier include flange, wafer, and adhesive. The pouch may also be referred to as a bag. Choosing a pouching system depends on a thorough patient assessment. To ensure the most appropriate system, the following stoma characteristics should be assessed: the type and frequency of the output, the consistency and amount of the output, the size of the stoma construction, including the location of the stoma opening, known as the lumen, and unusual abdominal contours and peristomal skin breakdown. The following patient requirements should also be assessed: manual dexterity, visual acuity, patient's level of physical activity, financial resources, and patient's preference. The location of the stoma on the body could be ideal or may create difficulty for some individuals to pouch and manage. The ideal location for stoma placement is a flat, clear area of the abdomen, free of creases and not in the bend line. A flat area maximizes the opportunity for ease with ostomy pouch placement, increasing adherence and successful outcomes. Less ideal pouching surfaces may be near an incision. This could require pouch placement manipulation to achieve good adherence to skin and not interfere with a dressing or cover the incision. Also less ideal is near or within skin folds. In addition to this being a more difficult area for the patient to visualize and apply the product, it may also include issues such as perspiration, which could impede the adherence of the ostomy barrier. The barrier is the most important part of the pouching system. It is the interface between the patient's skin and the pouching system. An appropriate barrier will provide a secure seal while at the same time protecting the skin. 3 goals of the barrier are: 1. Prevent leakage of stoma output under the barrier. 2. Protect the peristomal skin while being skin-friendly. And 3. Provide a predictable wear time. As the skin barrier begins to absorb moisture from the stoma output and skin perspiration, the barrier will erode or break down as shown in the photo. Although pouching systems are made to be worn for 3 to 7 days, it is of utmost importance to examine the erosion of the barrier upon removal. This will help determine the wear time of the barrier. Standard wear barriers are used for semi-formed to formed stool, typically with colostomies. Extended wear barriers are used for loose or liquid stool, urine, or high output stomas, typically ileostomies or urostomies. There are different types of barrier shapes: flat, soft convex, light convex, and deep convex. Flat barriers are ideal for normal stomas or normal peristomal skin areas. Flexible one-piece barriers are an option for areas that are rounded or in a bend. Convexity is a curvature of the barrier designed for those who do not have normal stomas or peristomal skin areas. Coloplast has several levels of convexity to meet different needs. Soft and light convex are for those with a flush, at skin level, or slightly retracted, below skin level, stoma. It may also be used for those individuals with loose skin, slight folds, a stoma that is tilted downward or not draining from the center. Deep convex is used for stomas that are retracted or recessed, in deep skin folds, or areas of heavily scarred or very loose skin. Convexity, or the outward curving of the barrier, is often used to manage difficult situations such as irregular abdominal contours or frequent leakage.
It is also helpful if the stoma is flush, causing the output to empty at skin level, or if the stoma is retracted, causing the output to empty below skin level. Using a convex barrier will cause the stoma to protrude due to the rigid convex surface of the barrier pressing down on the peristomal skin. Allowing the stoma to protrude over the barrier will assist the output into the pouch rather than undermine the barrier, which is often seen with a flush or retracted stoma. With a pre-cut barrier, the opening for the stoma is pre-cut or is sized for the stoma and ready for placement around the stoma without cutting. It should not be used in the postoperative period due to the changing size of the stoma. It can be used once the stoma size has stabilized. There are common pre-cut sizes such as 1, 1 1/4, and 1 1/2 inches, which are best suited for round stomas. A cut-to-fit barrier is cut to the size of the stoma before applying it using a pair of ostomy scissors. It is important to cut the hole so that it will have a snug fit around the stoma, going over the stoma easily, but not leaving any exposed skin around the stoma.
Pouches are used to protect the peristomal skin and collect the stoma output. They should provide a predictable wear time.
One-piece pouching systems consist of a solid barrier and pouch that are heat-sealed together to create a single unit. They are applied and removed as a single unit and can't be removed separately. Two-piece pouching systems consist of a solid barrier with a mechanism or coupling to attach the pouch. They may be applied as a single unit or individually. A barrier may be left in place while the pouch is changed. The barrier may only need to be changed once a week, but the pouch is changed twice a week, or in the case of a closed-end pouch, the pouch is changed after each bowel movement. Mechanical coupling systems consist of a solid barrier and a separate pouch, each containing a plastic ring that fit together. By snapping the barrier and the pouch together, the system locks in place. For added security, a locking mechanism may be incorporated into the system. This ensures the pouch will remain attached to the barrier. Adhesive coupling systems have an adhesive designed to secure the pouch to a base plate, which is attached to the barrier. When securing the pouch to the barrier, minimal pressure is applied to the abdomen. Adhesive coupling systems work well for patients who want an easy-to-use, flexible, low-profile, two-piece system with an ability to remove the pouch without changing the barrier. Ostomy pouches may be closed-end or drainable. Types of drainable closures are clamp closure, integrated closure, and small spout outlets designed for urine. The outlet is used for emptying the pouch without removing it. After emptying, the outlet is closed and the pouch is ready for further use. Drainable pouches with a spout or tap are used for urostomies. There are also nighttime drainage systems that patients can connect to their urostomy pouch using a connector and tubing that drains into a larger collection bag. This decreases how often they must get up to empty their pouch during the night. Patients with high output stomas should use drainable pouches due to frequent emptying. Drainable pouches have an opening at the end of the pouch, which allows stool or urine contents to be drained while the pouch remains in place. Transparent pouch. This pouch is made of clear film, making it easy to visualize the stoma for pouch application or monitoring of the stoma and output, especially post-operatively. Opaque pouch. This pouch has material or textile to prevent visualization of output. This pouch may be more discreet under light-colored clothing. Filtered pouch. This pouch has an integrated charcoal filter to allow gas, but not odor, to escape from the pouch. Filters are commonly used with colostomies, but may also be used with ileostomies. Non-filtered pouch. This pouch has no integrated filter and is often used post-operatively to monitor for return of bowel function and flatus. Urostomy pouches are non-filtered. Thank you for taking the time to view this module. For additional ostomy education, visit us at coloplast.us.